Talk about the pathophysiology of epiglottitis. Epiglottitis is an interesting pathology because the incidence of this pathology has reduced significantly since the introduction of vaccines. So the primary or the typical bacteria that was causing epiglottitis was hemoinfluenza type B or HIB, and this is commonly vaccinated against. So there is a vaccine that children receive against HIB. And as a result, we actually see the number of cases of epiglottitis in children reducing dramatically in the post-vaccine era. In terms of adults, the incidence of epiglottitis and supraglottitis has remained fairly consistent. And this isn't to say that we don't see epiglottitis in pediatric patients. It's just more rare than it used to be. What is interesting about epiglottitis in a post-vaccine era is that we are often seeing polymicrobial epiglottitis or epiglottitis as a result of varied microbes. So it's not as easy to diagnose or determine what the specific microbe that is going to be impacting patients is. And at times, you may actually see a polymicrobial approach where we actually have one or two different microbes that are leading to the epiglottitis. So that could be things like S. pneumonia or S. aureus. So we will often now see a polymicrobial infection, which may require additional treatments or more aggressive treatment. And this is especially true in patients who are immunocompromised. So that's something to be aware of if you think someone is experiencing epiglottitis, is that it may not be as easy, to diagnose what the specific cause is, and it may require more aggressive treatment because it could be varied or polymicrobial in its approach. So what typically happens with epiglottitis is it starts as an upper respiratory tract infection. So someone is going to have infiltration into the upper respiratory tract. So we'll draw kind of a nose in here. So this is a nose. What's going to happen is one of these infections is going to impact the upper respiratory tract. So we have colonization of the upper respiratory tract by some sort of microbe. So we'll start that in the flowchart here is that we get microbial colonization of the upper respiratory tract. And what's going to happen is that is going to lead to infection for potentially hours to days, but we typically see, especially in the microbes that we're looking at here, rather mild symptoms of upper respiratory tract infection. And because of this, what happens, or one of the things that happens, is epiglottitis often appears as though it comes on rapidly. What's really happening in these cases is the symptoms are very mild of the upper respiratory tract infection. And as the patient has a postnasal drip or we have inhalation of these microbes, the microbes can then move towards the epiglottis and the supraglottic structures. So we see the microbe actually moving down. So what's going to happen initially is we get microbial colonization of the upper respiratory tract. And following that, the patient is either going to have postnasal drip or essentially aerosolization as they breathe in the microbe, so postnasal drip or movement of microbe to the epiglottis or the supraglottic structures. And the problem is that once this happens, the patient can develop symptoms quite quickly. So as the microbe moves to the epiglottis or the supraglottic structures, it doesn't take long before that microbe, as it colonizes the epiglottis, it can lead to fairly significant symptoms, especially in children. So what we see happening, if we just draw in some of those cells, so we'll draw in some of these as being the cells of the epiglottis. So we've got our cells of the epiglottis here, and we have the blood supply, or basically this blood supply that's going to be provided to the epiglottis. What we're going to see happening is as those bacteria move their way down and begin to infiltrate the tissues of the epiglottis, it's going to lead to the release of inflammatory mediators. So as we'll say this is a bacteria or a microbe, enters the epiglottic tissue, it's going to lead to inflammation. So we're going to see those tissues becoming inflamed and irritated as the result of this bacterial colonization. And we're going to release inflammatory mediators. So the inflamed tissue will release inflammatory mediators. So we'll draw that in here. We have the release of these inflammatory mediators. And this is going to help recruit white blood cells. So as these inflammatory mediators make their way into the blood supply, we're also going to see white blood cell recruitment. So we'll have our white blood cells that are making their way to the area as well. And what happens is inflammatory mediators and white blood cell recruitment is going to lead to vasodilation. So we actually see our vasculature dilating and it becomes more permeable. So we get some vasodilation and an increase in vascular permeability. So as you can see here, the vessel is dilated, and these kind of fenestrations here indicate that the vessel is permeable. And as we see this increase in vessel diameter and the increase in permeability, what that allows is fluid to shift out of the vasculature and into the tissue of the epiglottis. So we can add that to our flowchart as we get the microbe or colonizing the epiglottis supraglottic structures. That's going to lead to colonization, or it starts to colonize in those tissues. That colonization is going to lead to the release of inflammatory mediators. So we see inflammatory mediator release. And after those inflammatory mediators are released, what's going to happen is we're going to see recruitment of white blood cells. So we see an increase in white blood cells in the area, and then we're going to see an increase in vasodilation. So what we are going to see is we start to see an increase in vasodilation and vascular permeability, which will allow fluid to shift. So we have fluid shifting and edema. So the fluid shifts into the epiglottis, and the epiglottis and supraglottic structures become edematous. So we get edema. And this is where kind of the risk is involved. And if we think about the pediatric patient versus the adult patient, there are a couple things that put them at much higher risk. If we draw in the airway of the ped, so this is our pediatric airway versus our adult patient here. So we've got our adult. One of the things that we'll note is that the pediatric patient simply has a smaller airway diameter. So one of the things we have to be acutely aware of is when we're looking at the pediatric versus the adult, is that the pediatric patient has a smaller airway diameter. So we're seeing less room for swelling or edema. So we have a smaller diameter versus the adult patient whose airway diameter is much bigger. The problem for that is that it's not proportional. So just because I have a smaller airway doesn't make me at smaller risk. It actually puts me at much smaller risk. And one of the reasons for that is that when we look at the pediatric patient, for every 1 millimeter decrease in airway diameter, they actually see a 16 times increase in airway resistance. So again, when we're looking at airway size, being smaller is more significant because as it gets smaller, there's less room to work with, which leads to actually a quite a significant increase in airway resistance. So it's not a proportional, it's not, the smaller my airway, I get a proportional decrease in airway resistance. The smaller my airway gets, I start to actually get an increase in the amount of resistance, or a much higher increase in the amount of resistance that I'm going to see. The other problem with the pediatric patient, or the difference in the pediatric patient, is that their epiglottis is located more anteriorly and superiorly, and it has an omega shape to it. So if we look at the pediatric epiglottis, it's got this kind of omega shape to it, and it's located more anteriorly and superiorly. So for the adult patient, it looks more like a typical epiglottis. So again, what we're seeing for the pediatric patient is the epiglottis is more anterior and superior than the adult. And it's also going to be omega shaped. So we have this kind of omega shaped. And it's larger because of that. So not only is it omega shaped, it's actually a larger epiglottis. Finally, there are some differences in just normal collagen development for the pediatric patient. So we actually see it's basically a floppier epiglottis or a less rigid epiglottis because the patient has more elastin than collagen, or we haven't seen normal maturation of collagen in the pediatric patient, which makes their epiglottis floppier or less rigid. It doesn't like to hold itself up as well. So one of the other kind of critical pieces to why epiglottitis is so dramatic in the pediatric patient is they have less collagen maturation, which means that their epiglottis is going to be floppier. So they have essentially just a floppier epiglottis, doesn't like to hold itself upright as well, which puts them at much higher risk. So what happens for this pediatric patient when they have a smaller airway, when they have an epiglottis that is more anterior and superior, and when they have an epiglottis that doesn't have as much collagen compared to elastin, which makes it floppier, is as you start to see edema. So we start to see an excessive amount of edema due to the fluid shifting that we talked about. So the epiglottis becomes edematous. And a couple of risk factors exist. One is that as the patient inspires, we start to see what's called a ball valve effect. Normally, the epiglottis, especially in the adult patient who has a rigid epiglottis, it's smaller, it's less anterior and superior, what happens is that epiglottis stays upright during inspiration. So what we typically should see is the epiglottis remaining upright during inspiration so the patient can inspire. Now, what happens in someone who has a less rigid, more floppy, a more anterior and superior epiglottis is that as the patient inspires, we actually see that inward pressure that creates a ball valve effect where this epiglottis will be pushed downwards, and it can actually allow the epiglottis to move downwards and inwards. We see this kind of movement down like this, and it obstructs the trachea as the patient tries to inhale. So a piece of it is the fact that as we get a swollen edematous epiglottis, it becomes heavier, and as it becomes heavier, it's much harder for the airway structures or the collagen and connective tissue that should be holding this epiglottis upright. As we breathe in, the weight of the epiglottis actually causes it to fall downwards, and we obstruct the airway, creating the signs and symptoms that we see with epiglottitis. The other problem that patients, especially pediatric patients, have, and you see this more commonly as patients have varied or polymicrobial infection, is that as the infection worsens, so as the patient's epiglottitis or supraglottitis worsens, those microbes can start to inflame the supraglottic and subglottic areas. So the areas around the epiglottis can become more swollen. So initially, what you're going to see is this increase in vascular permeability, this edema. This is all going to start at the level of the epiglottis. But the problem is that swelling and edema can actually progress to the sub and supraglottic areas. So we can actually see progression of edema to the sub and supraglottic areas, which is going to, again, reduce airway diameter, which puts this patient at risk. So epiglottitis can lead to, or can we see progression of swelling? So you can get progression of swelling, again, to the sub and supraglottic areas. And again, the big problem here is that we just create a smaller airway diameter. And that's going to lead for obviously less lumen size for air to get in. And as that occurs, then the patient's going to have a harder time breathing because airway resistance goes up, which can be quite negative in the pediatric patient. So just to recap, what's going to happen, or what we start to see happening, is patients will typically have microbial colonization of the upper respiratory tract. Symptoms here are usually quite mild. So again, this is associated with mild symptoms. And because of that, usually people will say that the epiglottitis came on out of nowhere. It came on very rapidly because this colonization happens quite quickly. So the colonization of the epiglottis will happen rapidly, and you'll start to see rapid onset of symptoms. So the patient's epiglottis will swell quite quickly, and the patient will suddenly have the signs and symptoms of epiglottitis. Following the swelling of the epiglottis, one of the big problems is that the edema increases the weight. So as the patient's epiglottis becomes heavier, or we increase the weight of the epiglottis, to increase the size and weight, especially in the pediatric patient, because they have less collagen, is it's going to promote a ball valve effect on inspiration. And what that means is as the patient inspires, the weight or the pressure of the inspiration is also going to push down on the weight of the epiglottis. It doesn't have the structural ability to hold itself up, and it will occlude the airway. So we can get this ball valve effect, which essentially is going to create an obstruction to the patient's airway. So they will present with signs and symptoms of airway obstruction. So what we can do is take a look at some of the signs and symptoms that we would expect to see in someone with epiglottitis as these things are happening. So what we will often expect, or what you'll expect to see in patients with epiglottitis, is usually a high-grade fever. So one of the signs and symptoms that we can expect to see is, well, first and foremost, signs of upper respiratory tract infection, and we've kind of targeted this here. That's where the microbe usually starts. And then we'll often see high-grade fever. If you think about what we said, these are usually bacterial infections, so we're often looking at bacterial or polymicrobial infections. And this is why the fevers can actually usually get quite high. So bacterial polymicrobial infections, if we're looking at the symptomology, why does this happen? As someone has an infection, we're actually seeing pyrogens increasing the set point temperature of the hypothalamus. And that's a regulatory piece for the patient in order to try and get rid of the pathogen or kill the pathogen. So we actually increase the set point temperature of the hypothalamus, which will lead to an increase in body temperature. One of the other symptoms that you often will see with these patients is they like to sit upright. And they actually will they'll sit upright with their nose in the sniffing position. And the reason for this is that the patient is actually trying to pull the airway or pull weight off the upper airway structures. So the patient is essentially trying to open the airway and lift the upper airway structures off of the supraglottic, epiglottic, and the subglottic areas. So patients are trying to open the airway and lift the airway structures off of those areas that are inflamed. So off the glottic areas. Patients will often be drooling. And that's because the patient will have difficulty swallowing. You think about the swallowing reflex, the patient will be trying to close the trachea during swallowing to prevent aspiration. Well, these patients will often have difficulty swallowing because there's so much pain associated with moving that epiglottis. So it's painful to swallow because of the movement of the epiglottis. So the patient will be in this kind of upright sniffing position, drool exiting their mouth, which goes along with the high-grade fever and the bacterial infection, is that the patient often also looks toxic in appearance. So they're looking quite sick. The patient may have difficulty speaking or painful speaking due to the swelling of the upper airway. And the big risk here, or the dramatic risk associated with epiglottitis, is the potential for airway closure. So again, you may hear some muffled voice as the patient's having a hard time actually getting air out. So with this drooling, you may actually see muffled voice as well. And we can start to hear stridor on inspiration and expiration. So that muffled voice and stridor is again the result of decreased air movement and lumen size. And that's at the level of the epiglottis. So if you think about the muffled voice, for example, these are our vocal cords. Our vocal cords are sitting below the epiglottis. It's very challenging for if someone's trying to speak for the air to move up through the vocal cords and then past the swollen epiglottis. That can lead to the muffling of the voice that we can see with these patients. At the end of the day, one of the biggest consequences of epiglottitis is airway closure. This is often considered a surgical emergency. So if the patient can't be treated with antibiotics and steroids, for example, the next treatment would be consideration of intubation and then potentially tracheostomy for these patients. So again, very important that this is recognized as a life threat, especially if it's able to advance to the point where the patient does get quite ill and you start to see those signs of airway closure. One of the big problems, again, as I mentioned, is that as the epiglottis swells, very quickly can it move towards swelling of the subglottic and supraglottic areas, which will essentially lead to airway closure because we have an epiglottis that likes to or is going to be prone to collapsing in on the airway. And if these other structures are becoming swollen and reducing lumen size even further, that is going to lead to full obstruction of the airway. So I hope that helps as a good review of the pathophysiology around epiglottitis. Again, one of the important things to recognize here, not just kids. Incidence, we do see incidence of epiglottitis in adults, with incidence in children actually reducing since implementation of vaccines.